students, now it is the time to know the cerebrovascular diseases in diabetic individuals. The stroke is one of the leading causes of the morbidity and the mortality worldwide. The annual incidence is 2 for 1,000 population in the developed countries. In India, much more because of the early onset to the diabetes, hypertension, smoking, etc. Our incidence may be 5 to 6 per 1,000 population. It affects 5% of the population over the 65 years of the age. Death rate following a stroke is around 25%. Unknown, uncommon below the age of 40 years and more common in the males. But in India, it is not uncommon below the age of 40 years. So young stroke is also very common. Subset is very common in Indian population. Stroke in young. So maybe because of the early onset of the diabetes or early onset of the hypertension or the vascular streaks like tuberculosis, vasculitis, or maybe other autoimmune diseases, vasculitis, lupus, rheumatoid arthritis, etc. Even the malaria acts like a vasculitis, malarial vasculitis CVA. So these are the very common. So stroke in the young is also very common in Indian population. So the strokes may be due to the thromboembolic infarction. So that is more common, 80 to 85%. Cerebral and cerebellar hemorrhages, about 10 to 15% of the patients. Subarachnoid hemorrhages in about 5 to 10% of the population. If you see here, hypertension is the root cause for all the three. So hypertension can cause thromboembolic infarction, can cause cerebral and cerebellar hemorrhages, and also can cause the subarachnoid hemorrhages. Okay. And if you see the thromboembolic infarctions, more cases are because of the hypertension. If you see the cerebellar and cerebellar hemorrhages, again the 90% of the cases are because of the hypertension. Clinical classification of the stroke: a completed stroke, a major or the minor, evolving strokes, and the transient ischemic attacks. Major stroke is the most common cause of an acute cerebrovascular accident caused by infarction or hemorrhage of the cerebral hemispheres. Reaches its peak in less than 1 hour, leaving the considerable residual deficit. Symptoms lasting longer than the 24 hours is a major stroke. So what we see usually in the casualties is the major strokes. So 80 to 90% of the cases. Minor stroke, the patients with a completed stroke improve rapidly with recovery from the disability over the course of the first week or the 2 is a minor stroke. So mostly the residual hemiplegias, they are the major strokes. Evolving stroke, stroke in evolution, describes the progression during the first 24 hours. Sometimes a slower course occurs, the disability advancing gradually over the several hours or the days, often due to the slow occlusion of a major cerebral vessel, internal carotid or the middle cerebral artery. Can also be due to the cerebral tumor or the subdural hematoma. TIAs are very common in our population. Episodes of focal neurological symptoms of less than 24 hours of duration, occurring as a result of reduced flow to the vessels from the fall in the perfusion pressure or blockage of the passage of the flow by embolism, arising from the plaques in the aortic arch, extracranial vessels of the heart. If flow is restored within the critical period, ischemic symptoms reverse, otherwise infarction may occur. No serious persisting disability in the TIAs. So these are all the symptoms. The posterior vessels, that is the vertebrobasilar territory, or the anterior, that is the anterocerebral artery. Suppose if you see the anterocerebral artery's involvement, the people will have the hemiparesis, hemianesthesia, monoocular blindness, also called as amaurosis fugax, dysphasia. See, these are all temporary. TIA, by the time they reach the hospital, already they are absolutely the normal. They have an history of some hemiparesis or hemianesthesia or monoocular blindness or dysphasia. If they involve the vertebrobasilar territories, the posterior TIAs, a loss of consciousness for a brief period, bilateral limb dysfunction, binocular blindness, vertigo, tinnitus, diplopia, dysarthria, and the difficulty in swallowing. See, mostly these are all the history. This is the posterior vertebrobasilar artery involvement. So, what are the risk factors for the strokes? The same risk factors for your coronary artery disease and also for your peripheral vascular diseases. So, hypertension, smoking, diabetes, lipids, polycythemia, thrombocythemia, high alcohol intake, positive family history, oral contraceptive use in the females, trauma. Okay, so these are some risk factors for the strokes. Diagnosis of the stroke, a clinical evaluation, CT scan, plain and the contrast, MR and MR angiogram, and the fellow is totally conscious, we will get the CT scan done. Because for the CT scan, the patient has to be stable. For MRI, he should be very stable. So if the patient is unconscious or irritable, it is very difficult to get the MRI scans. Then we will order only the CT scan. So the Doppler also will help you the strokes. See, this is a very important DD. So mimicking a stroke like brain tumors, subdural hematomas, brain abscesses, viral encephalitis, hypoglycemia, or hyperglycemic hyperosmolar state. So these are all DDs for your stroke. So when the fellow is a high grade fever, so it could be because of the brain abscess or encephalitis. Or a known diabetic with an history of the severe hypoglycemias, it could be a hypoglycemic episode. Okay, and subdural hematoma with a history of injury to the brain, and sometimes the brain tumors. So the management and the infarction. So general management, care of the airway, care of the back, bladder and bowel, fluid and electrolyte management, site-specific intraarterial thrombolysis, that is endovascular thrombolysis, anticoagulant therapy, surgical interventions and rehabilitation. See, the best way of managing the CVA is master inactivity and wait for the complications. So we can't do anything for the stroke fellow. So the only thing is wait and watch for the complications. So this is a very important factor for the infarctions. So persistent hyperglycemia is an indicator of the poor prognosis in a diabetic individuals. So when the blood sugars are very, very high, so definitely you have to use the insulin. What is the range? Blood sugars you have to keep between 140 to 180. 140 to 180. So insulin therapy should be considered if the random blood sugar levels are the high. Ideal to maintain the blood glucose between 140 and 180. If BP high, should be reduced cautiously. BP more than 180 and 110 is a contraindication for the thrombolysis. Now the TPA therapy is there. So when the patient is in the window period, so within the 4 hours, now they may be extended to the 6 hours. So you then go for the TPA, the thrombolytic therapy. So suppose if the patient is beyond the window period, so definitely we have to admit the patient and give the mannitol or with the neutrophil or with the citicoline and then the antiplatelet agents and the statins and etc. Okay. And here most important thing in the CVA is don't treat the hypertension very aggressively. So that is the most important take home message for all of you. So if the blood pressure, you always keep the blood pressure systolic above 160 and the diastolic above 100. So otherwise there will be the Steele syndrome, cerebral Steele syndrome. See, when the fellow is in the ischemic the brain zone, so that ischemic zone needs more blood. And if you keep the blood sugars at a lower level, so the blood supply may not reach to that ischemic zone. So you are doing more harm in reducing the blood pressure. Otherwise, you have to keep the blood pressure at above the 160 by 100 in order to reach the blood supply to that ischemic zone and then keep that ischemic zone into a normal zone. So otherwise that ischemic zone will go on, will further get the ischemia and then definitely there will be the necrosis and then the patient's response will be very, very poor. So in the presence of the hypertension in the casualties, don't give the dipin sublingually. So don't give the antihypertensives very effectively if the blood sugar is above 160 by 100. Keep the blood sugar above 160 by 100 in order to avoid the ischemic Steele syndrome. So the primary prevention, control the risk factors, diet, exercise, etc. In the secondary prevention, already had the CVA, then the BP control, glucose control, antiplatelets, statins, etc. For the tertiary control, tertiary prevention, you have the carotid endarterectomy and the stenting. Now the interventional neurologists are available, like interventional cardiologists. Now the Kakinada also we have 1 or 2 interventional neurologists. So they do the interventions. So this carotid endarterectomy and the stenting, just like the cardiologists. So, but this science is evolving. It's at the initial days right now. So most of the people, they are not for the thrombolytic therapy because of the cost factors, etc. But definitely And yesterday I have seen one retired teacher, aged about 75 years, with a history of diabetic and hypertension, with history of TIAs. Then he had internal carotid artery block, maybe about 85%. So he needs endarterectomy. Then I referred them to the interventional neurologist. So he advised carotid endarterectomy, and they have said about the pros and cons of the procedure. And then he needs the counseling from his family members also. And later he will consent for to go for the endarterectomy. These are all costly processes. And again, the process with some side effects and maybe the death also. So that is also possible with these things. Otherwise, he is conscious and coherent. He is capable of doing his own routine activities. But why I am saying this, that interventional neurology is also coming up. So as and when, suppose a young fellow, a professional, so he needs, so definitely we can subject them for the carotid endarterectomy for the better results. Thank you very much for your patient hearing. And if you have any queries, I will be very happy to answer them. Thank you. Thank you.